يعني at least studying for material for the next midterm, if we're gonna have one for next week. Okay, we might be having one next week. The material is going to be the first 4 lectures of the autonomic nervous system. Okay, so guys, I want you to start studying those, please. Okay, be ready for next week. If I tell you, you would know that I still have to see the logistics, when and how. Okay, but these are the main ideas. Okay, let's begin. So for adrenergic receptor antagonists, okay, we have, as usual, drugs that are for alpha and drugs that are for beta, okay? The drugs that are for alpha can be non-selective to alpha-1, okay? And can be selective for alpha-1 and alpha-2, okay? So non-selective, alpha-1, alpha-2. Actually, for alpha-2, we don't have any or many uses, okay? Can you remind me what's the role of alpha-2 in general?
Inhibition.
Inhibition.
Inhibition, that's right, thank you. So the role of alpha-2 is inhibition in general, okay? It inhibits the outflow of norepinephrine. And when it inhibits the outflow of norepinephrine, the result would be not any more norepinephrine coming out, okay? Usually this decreases the blood pressure, okay? But if we block alpha-2, that means we're inhibiting the inhibition. Okay, it makes sense? So when I block alpha-2, it's like I'm inhibiting the inhibition. All right, so the thing is, the result would be more norepinephrine outflow. I don't have any inhibition anymore, so I have more norepinephrine coming out. Okay, if I have more norepinephrine, that means more vasoconstriction, increase in heart rate, which are symptoms that I usually do not want. Okay, this is why alpha-2, guys, alpha-2 selective is not something that's usually used. We have one drug, okay, but usually it's not used anymore. It's a herbal drug. So the major ones that we're gonna focus on are the non-selective and the alpha-1 selective. Okay, and we're gonna talk about beta blockers as well. We have usually beta-1 selective as well, and we usually avoid beta-2 inhibition. Okay, because that will affect the lungs. All right, so
Doctors?
yes.
I have a question.
Yes, go ahead.
So if we have an antagonist for alpha-2,
Yeah.
actually will increase the activity of alpha-1, right?
Yes. So it does increase alpha-1, but it will increase the activity of alpha-1 and beta-1 and beta-2 and everything in the world, which will cause hypertension, okay? Increase in blood pressure, which is something that you don't want.
Okay, so it will increase the activity of all the adrenergic receptors.
Everything, which is not specific, not something that you want. Okay?
Okay.
All right, so now we're going to spend time talking about these, okay? The alpha non-selective. Okay, what about the alpha non-selective? Alpha non-selective, we have 2 major drugs, okay? Those drugs are called phenoxybenzamine, and phenoxybenzamine is irreversible, okay? And phenethylamine, which is reversible and competitive normally, okay? Let's go back here. So these drugs are, all of them are irreversible with the exception of phenoxybenzamine, okay? Usually, when I say selective, that means the drug will only bind to alpha-1, for example, or beta-1 or whatever. But if I increase the dose to certain amounts, the drug will lose its selectivity and will bind to everything, okay? Therapeutic uses are entirely caused blockade of alpha 1 and beta 1. What do I mean by it? Usually, alpha 1 and beta 1 are the drugs that we need. What is the effect? If I block alpha 1, usually, what am I doing? Guys, can you remind me where alpha 1 is present? Like in what places? What does it do? Yes, what does it do to smooth muscles?
Contraction.
Contraction. So what happens if I give an antagonist?
Relaxation.
Relaxation, exactly, guys. This is the point. Okay, so it causes relaxation. So it relaxes vascular and smooth muscles. So those are in vessels. So this causes vasodilation and also happens in many other tissues. We're going to talk about what tissues it involves. And blockade of beta 1 receptors, okay, which we're going to talk about next session, will lead to decrease in the heart rate and will decrease in the kidney production of renin, okay? And those are mainly. So we're going to talk mainly about alpha 1 and beta 1 blockade, okay? Antagonists for these receptors. But what about alpha 2 and beta 2? Listen, guys, if we block those, this will lead only to side effects, not something that we want. So we always try to avoid these receptors. Okay, so we agreed that alpha 2 is not something that we want. We talked about it. We said that means we have more norepinephrine, and this is not something that we want. Whereas blockade of beta 2, okay, is also something that we don't want. Why, guys? Where is beta 2 present?
Bronchi.
Yeah, what type of muscle?
Smooth muscles.
Yeah, where is beta 2 mostly? What is the major organ? It's present in smooth muscles, but there's one
lungs.
Yes, in the bronchi. Okay, the lungs. Okay, so this is extremely important when we talk about the lungs. So guys, what happens if I block beta 2? What happens to the lungs?
Well, contraction.
Shortness. Difficult breathing.
Yes, that's right. So we're talking about bronchoconstriction, which is not something that we want. Okay, guys, do you have an exam?
Yes, doctor.
Yes.
Yes.
At 9:30? Okay.
Yes.
All right, so I'll finish as fast as possible.
Thank you, doctor.
You're welcome. Okay, so listen, guys. So this is why we don't want beta 2. This that can lead to bronchoconstriction, and we never have advantages of having this. Okay, now for the non-selective alpha adrenergic antagonists, we have phenoxybenzamine and phentolamine. Okay, phenoxybenzamine is irreversible, making its duration of action super long. So that means 3 to 4 days. I'm not talking about hours, I'm talking about days. Okay, very, very long. Whereas phentolamine is reversible, I mean, it's competitive, okay? And the duration of action is super short, 10 to 15 minutes. Okay, so this means I'm only going to use it wherever I need. Okay, so I'm going to use the long-acting one if I need a long-term treatment, and I'm going to use the short-acting one if I need something that's so fast. Okay, since we're blocking both alpha 1 and alpha 2, what did we say about alpha 2? Is it something that we want?
No.
No. Okay, so this is not something that we want. Okay, what happens if I block alpha 2? The result would be vasodilation, right? Because no more, so I mean, what happens if I block alpha 1? If I block alpha 1, okay, the result would be vasodilation. Okay, so we agreed on it. But what happens if I block alpha 2? We have to look, guys, at one thing. If I block alpha 2, this leads to tachycardia. Does it make sense?
Yes, doctor, because we have vasoconstriction.
No. Not because we have vasoconstriction. We don't have vasoconstriction. Because we're blocking the blocking, okay? So when I block the blockade, when I block alpha 2, more norepinephrine will come out, and this will lead to more heart pumping, okay? That's it. So this is what I block alpha 2. And remember, guys, because of alpha 1 blockade, I have vasodilation. So if I have vasodilation, what's the result? Reflex? What? Reflex tachycardia. There you go. So reflex tachycardia. So I have reflex tachycardia, and I have tachycardia because of alpha 2, and that's too much of tachycardia. Okay? And that is a major side effect, guys. So one of the solutions is only to give alpha 1 because I will only have reflex tachycardia, not any more alpha 2 receptor blockade. Okay? What is another side effect? When we have vasodilation, what happens to the blood pressure? Decreases. So when someone is standing, what happens? They become dizzy, okay? And they will fall down, okay? This is what we call as postural hypotension. So they will have side effects that they will usually, whenever they stand, so this is related to posture. So whenever they stand up, they will be having symptoms like feeling dizzy, and they might fall down, okay? So they might have this issue of falling down to the floor. All right? So this is mainly the major side effects. So the major side effects are related to excessive tachycardia and postural hypotension. So why do we use them? Guys, do you remember pheochromocytoma? Pheochromocytoma, guys, was a tumor that happened in the gland that's on top of the kidney, okay, in the adrenal gland. That was a benign tumor that led to increase in norepinephrine release. Okay, so when there's more norepinephrine, we have more alpha 1 activation. That means we have severe hypertension. So if a patient has pheochromocytoma, what's the solution? The solution is to take the tumor out. It is surgery. But until I put the person into surgery, I need to control the alpha 1 receptors. I need to block them, okay? So for that purpose, I can use the irreversible form. Okay, so I can use phenoxybenzamine. Phenoxybenzamine will block alpha 1 receptors, okay, irreversibly for 3 to 4 days, which is good to treat hypertensive patients who have pheochromocytoma, because in that case, the alpha 1 receptors will activate. So that means contraction of the vessels, which is not something that we want. If I block alpha 1, no more norepinephrine coming, no more pheochromocytoma hypertension. Okay, so this is a very good treatment. And also to prepare patients for surgery, because while the person is in the surgery, there might be a sudden increase or activation of the adrenal gland. That means a sudden increase in norepinephrine, which is something that is also not good for patients with surgery. Okay. Phentolamine is the irreversible form. The reversible form, the competitive form. And that is the duration of action of phentolamine is 10 to 15 minutes. Okay, so there are reasons where I want only a small effect. What is that small effect? Usually, let's say someone has, remember when I told you someone might, if they have an EpiPen in their hand, okay, so they might be self-injecting their fingers by mistake, and that leads to severe vasoconstriction in their fingers. So this is the first solution to prevent that problem if it happens, to prevent its side effects. Okay, so I usually inject phentolamine for 10 to 15 minutes. It will block alpha 1 receptors. I don't have any more severe vasoconstriction, only for 10 to 15 minutes. Okay, also, if someone is going to the dentist office, okay, okay? And they usually have anesthesia injection, okay? Usually in that injection in the mouth, anesthesia is mixed usually with norepinephrine, usually to prevent excessive bleeding, okay? And usually to prevent the anesthetic, okay, so the anesthesia medication to move to other or to go away. Okay, so sometimes because there's severe vasoconstriction because of the anesthesia, some patients this will take time to go away, okay, which is not good. So in order to help those patients, to help the effect of the anesthesia to go away, I usually give phentolamine. Duration of action is only for 10 minutes. I can give the patient to help relieve the anesthesia. Okay, now they have vasodilation, the anesthesia will go away, and the effect will go away in 10 minutes, and this is what we want. All right, do we have any questions? Hello, do you have any questions? Guys, do I have anyone listening? Or are you all, all busy with the exam? طب guys, let me finish the side effects so I'll be done. خلاص. Okay, because I know you're all not listening. Most of you يعني. Okay. What are the side effects? We agreed that hypotension will cause vertigo, which is when someone is dizzy, okay? Also, this will cause very bad cardiac stimulation, very bad tachycardia, and that can lead to arrhythmias, which are excessive. Arrhythmias is unstable heart rate, unstable electricity in the heart. And also that might cause myocardial infarction, which means a heart attack, okay? This will also cause reversible inhibition. Okay, so inhibition of ejaculation. Ejaculation, that means we're stopping the smooth muscles of the vas deferens, all right? And phenoxybenzamine is also might cause cancer in certain experiments that were done on animals, so it's not the best drug to be using all the time. All right, so these are the major side effects. So if this is the job, or this is epinephrine, if I have B, this means this is reversible, so this is phentolamine, and C is irreversible, so this is phenoxybenzamine. All right? Okay, and the final slide, I want you to focus somehow with me. Okay, just focus for 5 minutes and I'll set you free, guys. Do you have an agreement? Yalla, focus with me just for 5 minutes. I'll set you free soon. Okay, so listen. Yeah, this is over here. We have an increase, okay, in the, look at only the black line. We have an increase in the blood pressure, okay? And this is after the injection of epinephrine. So epinephrine increases blood pressure, and this is something that we know, okay? Type. What happens if I block alpha before I give epinephrine? If I block alpha 1, the only receptor that will be active in the vessels is only beta 2. So what will happen if I give epinephrine? Epinephrine will no longer activate alpha because it's blocked. It will only activate beta 2. And what happens when it activates beta 2?
Vasodilation.
Vasodilation, thank you, Mayada. So vasodilation, so this will lead to decrease in the blood pressure. All right, so epinephrine activates alpha and beta. Alpha 1 and beta 2, both of them. So if I block in the vessels only alpha 1, if I add epinephrine, only beta 2 will be activated, and that will lead to vasodilation. All right? Whereas phenylephrine here is an alpha 1 selective agonist. So phenylephrine alone will increase blood pressure, but if I block alpha 1, phenylephrine doesn't act on anything else. So this will lead to a straight line because I don't have beta 2 activation to decrease the blood pressure. Makes sense? All right, great. Yalla guys, you're free to go. خلاص. Not gonna
Okay, doctor.
make it hard on you more.
Thank you, doctor.
Okay?
Did you take
We'll agree.
attendance?
Thank you, doctor.
Attendance later on. Okay, you can leave now.